Our next speaker is Mr. L. Hawkins. He's a sex and relationship therapist with years of experience as a renal social worker. She's going to talk to us about dialysis and sexuality. Welcome, Mr. L. Hawkins.
Thank you so much, CJ. And I'm so excited to be here today to talk about dialysis and sexuality. As CJ mentioned, I'm currently working as a sex therapist, sex and relationship therapist with Los Angeles Sex Therapy. But I did have several years of working as a renal social worker. And during that time, I would tell people, oh, you know, I got into social work to be a sex therapist and to work around sex and sexuality. And people would often laugh and say, oh, well, how did you end up in dialysis? And I was able to share that actually dialysis has a lot of impacts on sexuality and intimacy. And so I'm really excited to be here today to share. For my disclosures, I'm also the creator of dialysexy.com, which is a free online resource for providers and patients. I did not receive any funding from anyone to give this presentation, but if you know someone who wants to pay me, then I'm here for it, so let me know. As we go further into our presentation today, I want to give some context for where the information was taken from. So there were studies and they were completed in different countries across the world. And with that being said, most of the studies and papers did call for more research, that this is an area that even though it's really prevalent in impacting folks who are living on dialysis, that it's something that isn't really well researched, and we're even earlier in the process of understanding ways that we as renal healthcare providers can support patients through these concerns. And then going into this presentation, there's just certain things that we hold to be self-evident here. And so one is redefining sexual wellness, that we'll talk about this later on in the presentation as far as kind of understanding our definition of sex and sexuality. So in this presentation, sexual wellness is defined by the ability to access pleasure and connection to an individual's level of interest, and not necessarily by the ability to participate in or the amount of interest in specific acts. For gender and physical sex, we know that that's diverse and expansive, and it can develop and shift throughout a lifetime. So people with diverse and expansive identities are deserving of sexual wellness, everybody across the spectrums of gender and physical sexuality. You may hear in this presentation me refer to people as men or women, and that's just a reflection of the research language. Unfortunately, in research, we know that gender expansive folks and anybody who kind of falls outside of a binary is not usually pretty well represented. So we're limited by the research that is out there. Similarly, sexual orientation is diverse and expansive and can develop and shift throughout a lifetime, and people of all orientations are deserving of sexual wellness. And then finally, for this presentation, we're basing it on the concept that people have a right to pursue sexual activities and interests if all people are consenting human adults. And so really what you'll see as a theme here as I move forward is this idea of crafting sexuality and sexual experiences and intimate and erotic connection to be really tailored to the person, and to be able to be more expansive than maybe some cultural ideas that we have about sex and sexuality. So the objectives for today is to, one, demonstrate the importance for each and every renal healthcare provider to be addressing sexual concerns with patients. Two, to provide a framework for discussing sexuality concerns with patients. And then three, to review a couple common factors for renal patients that impact sex and intimacy. Because we are taking such a big topic and putting it into a 30-minute bracket, I won't be able to go over all of the factors, or even a more expansive list of the factors that might impact sex and intimacy for renal patients. But if you do request a copy of the deck, it does have more than what I will be going over today. So how are we going to go about meeting those objectives? First, I'm going to be talking about the importance of addressing these concerns and really looking at sexuality as an important component of quality of life and healthcare. Next, we'll be talking about some basic skills, including establishing boundaries and a model for you to consider when you're engaging with patients regarding sexual issues. And then we'll talk about a couple common sexual concerns and then wrap up. So for this first part, the importance of addressing sexual concerns with renal patients and sexuality as an important component of quality of life and healthcare, we turn to the research. So why is talking about sex with patients important? So there are studies that suggest that there's a pretty significant link between sexual function and perceived quality of life. And we know that there's a strong correlation between quality of life and a patient's ability to continue to pursue their medical care for dialysis. Sexual issues can lead to depression, eating disorders, alcoholism, and other mental illness, and that secrecy and silence are associated with shame and guilt, which can contribute to poor mental health. And another reason why it's important to talk about sex with patients is because it's important to them, that patients perceive their sexual health as important and worthy of attention. And so when we think about talking about sexual health with our patients, it's important to think of it not just for the sake of quality of life and because it's important to them, but also as preventative care for other mental health and physical conditions. And in particular, talking about sexuality with folks on dialysis is important because dialysis patients face pretty unique sexual concerns in addition to common issues seen in the general population. So sexual concerns are pretty prevalent in general population. About 30% of men and 60% of women in general population report some kind of sexual concerns. In dialysis, it's about 60 to 70% of dialysis patients. So we do see a disproportionate concern here. Some unique physical factors that impact sexuality for dialysis patients can include experiences of pain, fatigue, hormone imbalance, uremia, anemia, leg cramps, medications, and other medical issues. All of these things can impact someone's ability to experience pleasure or their level of energy to be able to have connection with themselves and others. Some psychosocial factors that can impact sexuality is experiences of anxiety, depression, sleeping disorders, body image, and changing of role or identity within their family or their relationship structures. So we can understand why, on top of just the general experience of being human, which we know does impact and cause some sexual concerns, managing all of these other physical and psychosocial factors can really create a bunch of challenges. And we want to be thinking about ways that we can be supporting our patients as they're navigating these topics. And so you might be thinking, okay, Elle, that's all well and good. Somebody should probably talk to patients about sex and sexuality, but why does it have to be me, right? Why do I have to do it? Well, so we can't sit back and hope that someone else is talking to our patients about sexuality, because unfortunately, research shows a really pervasive tendency on the part of the nephrology healthcare team to avoid addressing sexual function issues with patients. One study showed that while 70% of transplant survivors said that they wanted their healthcare team to provide information on sexual function, only about a third of the patients received this information. So there's definitely a gap between desire and need for information and that information being provided. Another thing is that refusing or neglecting to talk about sex reinforces shame. And so this includes those times when a patient might come up to someone and ask something related to sexual health, and that practitioner changes the topic because they're feeling uncomfortable. They don't want to talk about it. And so that can be really important to know, is that anytime that we're given the opportunity to talk about sex with a client or a patient and we don't take that opportunity, that actually can be internalized as a shame response. And as mentioned earlier, that can actually lead to other mental health or physical concerns. And so the really important thing to think about here is that unless the practitioner, unless you are comfortable talking about sex, the discussion will not happen. That we live in a culture that really enshrouds sex and sexuality with shame, and that doesn't give us a lot of information about how to have these conversations in appropriate and productive ways. And so patients rarely broach concerns regarding sexuality with healthcare professionals. And so if we don't ask about it, there might be something going on that we don't know about that could be impacting their primary relationships, and that can be impacting their quality of life and their self-esteem and their ability to engage with care. The other thing is that patients might have negative experience with previous practitioners. Unfortunately, we really do live in a culture where people will talk to their healthcare providers, people that they're entrusted to engage with around quality of life discussions, and then have that be reinforced with shame or have those experiences be minimized. And so, or flat out be responded to with really inappropriate kind of feedback from other healthcare providers. And so by being a provider that feels confident, capable, and is proactively bringing up sexuality in an appropriate way, it can actually be a very healing process for people, and it can allow them to talk about things that they may have been curious about or wanting to talk about for years. And all of that being said, if you are not feeling comfortable about your ability to talk about sex and sexuality with patients, you're certainly not alone. And that's part of why I'm doing this presentation today, is that many healthcare professionals believe that they haven't received the necessary training to adequately support patients around sexual concerns. And so some common barriers are being afraid of what the patient's reaction might be if bringing up sexuality happens, being afraid of judgment from colleagues, not feeling that they have the skill set or education about sexuality that's needed. There could be cultural, personal, and religious factors that come into play. What are the messagings that we got as we grew up around sexuality and shame and the appropriateness of discussing sexuality? Or a belief that an in-depth understanding of sexual functioning and treatment methods is unnecessary, which, as we just discussed, is simply not true, that it is absolutely very important. So I'm seeing some stuff coming up in the chat, and I'm seeing some questions about erectile dysfunction and libido, and we're going to get to those. So hang on just one moment. All right, so now you're saying, okay, I hear you. You want me to talk to patients about sex and sexuality. It is important, but I don't know how to do it. So that's why we're going to talk about basic skills for talking about sex in a professional setting. And luckily, there's actually a model that was developed exactly for this, for healthcare providers to talk to patients about sex and sexuality. It's called PLICIT, and it stands for permission, limited information, specific suggestions, and intensive therapy. And I'm going to go more deeply into each of these, but it's helpful to think about this as just being a checklist that you start at the top and you work your way down. And it might be that talking to someone and just permission giving helps to resolve their concern. It might be that they need a little bit of limited information to help them contextualize what's happening. It might mean that they need specific suggestions, or you might need to refer out for intensive therapy. And when we talk about intensive therapy, that could include psychotherapy. It can also include hormonal therapy, more in-depth medical support, but just basically anything beyond giving specific suggestions. So thinking about permission, as I've mentioned throughout the presentation so far, there are a lot of cultural barriers around talking about sex and sexuality, and there are a lot of shame traps that people are existing around when it comes to sex and sexuality. So asking permission is really important. I do want to say that I'm adding, when I think of permission, I not only think of asking permission, but also giving permission. And so those are the two lenses that when I'm first bringing up sexuality with people that I'm thinking about. So talking about asking permission, this gives the opportunity for the patient to opt out if it does push their cultural or personal boundaries. And it does model consent and empowers the patient to set boundaries, which we always want to do. We don't want to force anyone to talk about sex or sexuality. We want to normalize talking about sex and sexuality. Now, this being said, I encourage you to consider the way that you're asking for permission. Saying to someone, I know that this is, really weird and uncomfortable, but I got to ask you about sex and sexuality. It's going to land different and make someone less likely to open up about sex and sexuality because it's reinforcing this idea that talking about it is abnormal or kind of a burden or uncomfortable. So when you're asking permission, making it seem very normalized, and I'm going to give an example on the next screen of what that might look like, can actually just be an intervention in itself by asking permission in a normalizing way. Giving permission, so thinking about using non-judgmental language when we're talking to people, normalizing the prevalence of sexual concerns or sexual issues, and then addressing sexuality as a normal component of healthcare and quality of life is really important. So an example of what you might say when you're talking about consent is you might say sexuality is a natural part of the human experience and an important part of your healthcare. So it's my job to provide information just like any other aspect of your health and wellness. And you can say, is it okay to talk about sex and sexuality with you today? But this is an example of a way that you might broach the subject without kind of triggering shame or judgment. Another thing to think about when you're in the permission stage is clarifying boundaries. So some things that are helpful to do is to acknowledge that talking about sex and sexuality might feel uncomfortable, but that it's absolutely appropriate for them to talk about specific concerns that they're having and ask questions related to sexual health. You can remind them that just like any other aspect of their healthcare, you're there to focus on them and their needs, that it's not going to be anything that you're talking about your experiences of or that you're sharing energy around, is that you're showing up to help navigate a part of their quality of life and their healthcare that's important to them. So next, limited information. I went back a couple, sorry. Okay, so limited information. This can be things like a medication review and providing information on possible side effects. This can be redefining sexual success as pleasure is the measure, which I'm going to talk about in a moment. This can be educating on the impact of dialysis on sexual functioning and relational dynamics. And then thinking about where you hear shame, normalizing sex as natural and part of the human experience. So taking a moment to think, how do you define sex? You can see here, there's a wide variety of responses, and this was just taken from a small poll of social work interns or people in social work school. And you can see here that there's anything from it's related to physical pleasure, it's a fun physical act. Think of it as when a penis is inserted into a vagina, anything that brings me sexual pleasure. So there's a lot of different definitions that people have of what is sex. So I'm going to offer this definition because it's a bit more expansive and creates opportunity for people to engage with sexual connection and sexual pleasure despite changes that might be going on in their body. So thinking of it as sexual success is not defined by a person's ability to complete certain acts, but rather by their ability to enjoy their erotic interactions with themselves and others. So specific suggestions can be things like talking about use of lubricants, use of different sexual aids, use of erotica, non-sexual touch activities, or I would say non-genital related touch activities also. Modifications to address access concerns. Sometimes folks on dialysis are having difficulty because they're wanting to engage in sexual activity, but they're worried about the impact on their access. So getting really specific suggestions about how to keep their access safe can help them. And this can also be encouraging them to get tested for hormone levels, that sort of thing. When you would refer out is if you hear someone talking about sexual abuse or trauma history, that would be a great time for them to connect with a therapist to help process those things. Hormone therapies, need for specialized or intensive coaching, physical therapy, or if there's other possible underlying health concerns that need to be addressed. So some best practices as you're navigating talking with clients is promoting clarity while using their language. So on one hand, you want to reflect the patient's language as much as possible. So if they say, I'm just not interested in sex that I used to be, then using the term not interested in sex is better than saying, oh, so you have hypoactive sexual desire. That just puts it in much more clinical terms that can be difficult to understand and can also take someone out of their experience. So mirroring the language can build rapport and support the patient's understanding. However, sometimes patients might use language that is unclear, or they might use language that feels uncomfortable to mirror. And so a framework that I like to offer for the language that's uncomfortable to mirror is there's cool, warm, and hot language. And so as a practitioner, you want to keep your language more in the warm and sometimes to the cool spectrum, not the hot language. Hot language would be kind of like slang that we're used to hearing around genitalia, that sort of thing. So an example here is that if someone's talking about their vajayjay, you can say, I believe what you're talking about is your vagina. That means the canal that's inside of you. Or do you mean the outer part, which is the vulva? And that can be important sex education. It can be clarifying language. And it can also then kind of center you in that more like warm to cool language that's still in alignment with what they understand. Some other principles to think about are never assume and always assume. So never assume is the idea that we want to use terms that would work for anyone. We don't want to assume their sexual orientation, gender identity, or relationship style. An example of this is using the term partner and saying, instead of saying like your husband or wife or girlfriend or boyfriend. Always assuming. So this is the idea of normalizing. So when we use questions or statements, we want to use language that normalizes. So the idea of asking, do you masturbate? That can kind of trigger this idea of like, oh, is it normal to? So instead of saying, do you masturbate, saying, how often do you masturbate? And then really, as we're thinking about every interaction here that we're having with someone, we want to be focusing on shame reduction, not reinforcement. So maintaining an objective and compassionate stance while hearing about patients' interests and concerns is of utmost importance. So jumping into some common sexual issues, we're going to be talking about erectile dysfunction, impact on orgasm, and changes in desire. So erectile dysfunction is an inability to attain or maintain penile erection sufficient for satisfactory sexual performance. And this can be seen in about 40 to 80% of hemodialysis patients, and it's impacted by a variety of factors. One can be uremia, vascular problems is another, medications, hormone levels, depression, stress, decreased appetite. So a good litmus test is checking in to see are they having erections when they're sleeping at night? Are they having erections during certain situations, but not others? Because if they're able to get and maintain an erection, then it's a pretty good litmus test for whether this might be a psychological based factor or physical based factor. And that's going to obviously determine what you might share with the patient as far as opportunities for them to explore further. So, thinking about this, some important interventions are going to be that medication review, and here's some different medications that can cause erectile dysfunction. It can also be normalizing. A lot of times, people who are experiencing erectile dysfunction can feel really outside or othered, and they can feel often, if they identify as man, as like less than a man because of the way that their penis may or may not be responding to stimuli. Another thing can be providing that education around pleasure as the measure, that a relaxed penis is able to experience pleasure, and that someone with a relaxed penis is able to engage in other kind of pleasure-seeking behavior outside of just penetrative sex. Difficulty with orgasm. So orgasm is defined as a total body experience, which includes rapid heart rate and breathing, flushed skin, swelling of the head of the penis or clitoris, and a feeling of tension and release. Orgasm may or may not be accompanied by ejaculation, and ejaculation may or may not be accompanied by orgasm. We know that about 40% of male patients and 55% of female patients on hemodialysis have difficulty in achieving orgasm. Some important things to share with patients is that it's not limited to genital stimulation. Orgasm is actually a mental phenomenon, and it can be achieved through stimulation of other body parts and even through fantasy or without any kind of physical stimulation. So providing information about orgasm can help to expand someone's idea of how they might connect with orgasm. It's also interesting to note that women waitlisted for kidney transplant reported higher orgasm scores. Sexual desire. And so sexual desire has been found to decrease in almost half of people receiving dialysis. And contributing factors to lower desire include fatigue, medications, body image concerns, changes in relationship dynamics, and stress. When talking to people about sexual desire, it can be helpful to give them the framework of the dual control model. And so this is the idea that sexual desire, rather than being a drive, which is what we think of, either you have it or you don't, it's actually a system of exciters or accelerators and of brakes or stops. And so educating someone about that can help them start to think about what are their brakes, what are the things that turn them off or lower their desire, and what are the things that turn them on or increase their desire, and how to play with those two things to help move them towards a space where they're having the type of desire that they want to be having. So some additional interesting notes that I wanted to share is that women waitlisted for kidney transplant indicated better outcomes regarding sexual desire, satisfaction, arousal, orgasm, lack of sexual pain, and lubrication. Of course, there's a question here of correlation. Is it because that women waitlisted for kidney transplant tend to be healthier or younger? But I do think that there really is something there around the idea of installation of hope and around the level of activity that people have. Other research showed that people who were retired, women who were retired, were less likely to have score high for orgasm as well. One study showed that the level of acceptance of the patient's illness relates to their level of sexual function and satisfaction. So really being able to check in and see how is this person adjusting to dialysis, and knowing that moving them towards more acceptance of their diagnosis and of the need for dialysis can actually move them towards a place where they're feeling better about their sexuality and their sexual selves. So I was unable to find a study that reviewed the impact of quality in life of patients who had received support in increasing sexual satisfaction. I'd be really interested to see the results. I don't really know of any renal healthcare teams out there that are really proactively addressing sex and sexuality. And I think that that would be very interesting because of the way that many of our patients who are on dialysis, their primary care provider is also their romantic provider. And we know that that can really impact their ability to access care if they have a satisfying relationship with that partner. And if that relationship is in good states, then they're going to receive more support, which is going to help them to be more successful on dialysis, or at least that is my theory. So some final takeaways here. As a healthcare provider, your understanding of sexual health and your comfort in discussing sexuality as a normal part of wellness is key. Just the idea that you would be able to have a supportive and non-judgmental conversation with someone can help to diminish shame, and that can increase their sense of quality of life and their sense of satisfaction in their sexual self. Talking about sex is normal, healthy, and encouraged. And even just creating a supportive and compassionate environment can start to break down shame and stigma and sexual well-being. Healing starts with you. I have some helpful resources here, but I'm going to go ahead and jump into questions.
Great, thank you so much. This is a great talk. We have many questions in the chat, and I think you also already answered one of the questions. There's quite a bit of comment too. Let's see. Let me pick. Let's see. So Haynes Ramon asks, in case I missed it, if it was mentioned in terms of patient demographic based on your research, is it more men or women who has sexual frustration versus satisfaction?
Yes. So it was prevalent for both. For men, the primary issue appeared to be around erectile variability, so changes in their erection. And for women, it was often around desire, but also ability to orgasm shifted in both men and women as well. Mhm.
Okay. There's one. Wendy asks, what would you say when talking with a patient who is single, no relationship, and listed sexual problem on the KD-QOL?
Yeah, I would definitely ask more about that. Just because someone's not in a relationship doesn't mean that they're not engaging in sexual relationships. And also that sex can include sex with yourself. And so someone might have had a masturbation practice or an personal erotic practice that was really meaningful to them. We know that masturbation, self-pleasure, and orgasm actually have a lot of benefits as far as like managing anxiety, releasing stress, that sort of thing. And so even if someone's not sexually engaged with someone else, if they had a change in their sexual functioning, it can be impacting their own experience with themselves.
Great. There's a question on the KD-QOL. I'm wondering whether we should, looks like there's only one question on the KD-QOL on sexuality is, does kidney disease affect your sex life? Maybe we should have more questions on that.
Yes, I agree. I would love to see pretty robust conversations about sex and sexuality happening as someone is starting to get onto dialysis. So letting them know that this is normal, it's something that they might experience ahead of time. And that really opens the door for more conversations as changes are happening, and for people to feel like they can come to their providers and talk about changes that are happening.
Okay. And Christy has a question. What do you suggest to say to older individuals who have resorted to the fact there is just the way it is, but then later in the conversation, it's clear that missed that connection?
Mhm. Yeah, I've definitely had patients, you know, write back like just a smiley face or an LOL or something on the KD-QOL. And when I ask, they say, "Oh, it's because of my age. I'm too old for that." And I really let people know that's not necessarily the case. We've never seen a higher rate of STIs in nursing homes than we do right now, and that people can have sexual experiences until the end of their days. A wonderful resource to follow on older sexuality is Joan Price, who I believe she's in her late 70s, maybe even going into 80s now. And she talks about aging and sexuality and how you can have a vibrant sex life as someone who's older.
Now, last question, I would say, in your practice experience, any difference in terms of hemo versus PD versus home hemodialysis?
Mm-hmm. Yeah, absolutely. So, and there is some research to show that sexuality is less impacted on peritoneal dialysis. Some of the ideas with that is that you're getting better dialysis, so you're not feeling as much fatigue and some of the other side effects as hemodialysis. You're also more likely to be working if you're doing peritoneal dialysis, and having an active lifestyle is really helpful for things like sexual functioning and sexual desire. So talking about the type of dialysis that someone is doing and how is that supporting other aspects of their lifestyle can really be beneficial to folks as they're trying to figure out how to be living their most sexually vibrant lives while also being on dialysis.
That's wonderful. We probably should incorporate in that option class when we talk about CKD patient on different dialysis, when we recommend, then that's one of the things we should say the advantage of peritoneal dialysis.
Mm-hmm. Yeah, I know on some peritoneal dialysis, there's some modality options information that I have seen that on there. But I think, and I always would highlight it when I was talking with patients. So
Great.
Yeah.
Great. Thank you so much.
Oh, absolutely. Thank you for having me.
You're welcome. Bye.